I'm glad to present iatrogenic ruptured abdominal aorta at iliac bifurcation site during the removal of an unexpected disconnected Ansel guiding sheath. Iatrogenic aortic dissection is a rare but recognized complication. In early series, angioplasty-induced dissection and other acute events developed in 4 to 5% of cases. I got an emergency call from angio-cath suite. After coronary angiography, unexpected fractured and disconnected Ansel guiding sheath and left EIA occurred. During an endovascular procedure to the left SFA long segment CTO by crossover technique. This is preoperative CT angiogram. The CT showed long segment chronic total occlusion and left SFA. This is an angiogram performed by other doctor. He said to me, it was so difficult to advance the Ansel sheath to left CFA, and then Ansel sheath was fractured, and I tried to retrieve Ansel sheath, however it was very difficult too. Unfortunately, 035 guide wire in Ansel sheath was removed accidentally, and about 5 cm fractured sheath with supportive wire remained and left EIA. The problem is that supportive wire of Ansel sheath was very sharp. You can see here in this picture taken after operation, and right common femoral artery was lacerated during the manipulation of it, and bleeding was so severe at right CFA puncture site. During our discussion, BP went down sharply and mentality got rosy, because the right puncture site was well compressed. So there was no evidence of hypertension due to right common femoral artery site bleeding. So I thought that iliac bifurcation site might be injured while trying to remove the sheath due to the strong and sharp trauma by supportive wire of Ansel sheath. This picture was taken in operation room. After hydration and sedation, vital sign became stable. Because of stable vital sign, due to maybe contained rupture, I thought it is better to check a CT angiogram and to evaluate the severity of iatrogenic aorta injury. If vital sign had been very severe and unstable, I would place aortic balloon occlusion catheter and perform emergency laparotomy. This is an emergency CT angiogram. There was contained rupture at iliac bifurcation site. Because of urgency, I decided to do aorto-uni-iliac bypass operation to seal up iliac bifurcation rupture site, and if possible, to remove the fractured Ansel sheath, which would be a sort of medical issue. First, I exposed right common femoral artery, which was severely lacerated, and I performed patch angioplasty. You can see this is a supportive wire of Ansel sheath, very sharp. These are procedure schema of Ansel sheath withdrawal. Fortunately, I could pass 035 guide wire in Ansel sheath through left common femoral artery, and I snared the wire through right common femoral artery. And then I inserted Cordis 8 French curved sheath with dilator through right common femoral artery, and I could advance the disconnected Ansel sheath to the left common femoral artery with this direction. Following this direction, I could pass 035 guide wire in Ansel sheath. After that, I snared it and I rolled it for this 8 French covered sheath. I could push Ansel sheath to left common femoral artery. Ansel sheath was removed successfully from the puncture site of left common femoral artery. After that, I introduced the aorto-uni-iliac graft into the vortex graft, which was anastomosed to right common femoral artery, and I performed right common femoral artery to left popliteal artery bypass operation. Finally, I did embolization at left CIA and EIA to set up the iliac bifurcation rupture site completely. This is post-op follow-up CT angiogram, no endoleak, no post-operative complications. So all the interventionists should promptly recognize this rare but potentially fatal complication and have an understanding of pathophysiology in order to implement appropriate treatment option. Thank you for your attention.